For the postgraduate sake, just add a few slides. A peripheral cornea is a very unique portion of the eye because an avascular structure meets a vascular structure. So at that junction, there is a lot of issues because there is a limbal arcade which bring in immunoglobulins and inflammatory cells, and it's also actually the lymphatics of the eye is there, and Langerhans cells, the IgM, C1 proteins, and there is a continuity of sclera, episclera, and all these things. So that area is potentially a very interesting area and also a very potent, immunologically very potent area. So pathophysiologically, you have to understand the primary disease before going into the surgical aspect or a medical aspect. The immune alteration, because 50% of all the non-infectious PUK have collagen vascular disease. So you have to understand that most of the patients who have a peripheral corneal problem, they may have collagen vascular disease systemic. You have to at least 50% have. So evaluate them properly, because most of them are uncovered sequential antigens. They are very, very strong and they're mostly altered antigens. So just a pathophysiology, the immune reaction, when immune reaction occurs, there is an antigen antibody deposit, complement activation, and there is a cell attraction, and this causes lysosomal enzymes, collagenase proteins, all these things get released, and then this causes stromal melting. In vasculitis, sometimes the vascular wall inflammation occurs, causing an intravascular clotting, ischemic necrosis, and again melt. And in SINS, because of alteration, surgically induced necrosis, when you do a procedure, there is a fibrosis and there is an antigen anticomplex entrapment in that, and that's why you get a stromal melt. So this pathology is important because we have to make a barrier when you do a surgery to prevent all these collagenase, all these ischemic necrosis happening. So clinically, when you see a PUK, typically you have subepithelial infiltrates and then they coalesce, epithelial breakdown. The stromal melt is much faster than the epithelium. That is why you have a overhanging edges here, and there is significant adjacent limbal inflammation. So they can be potentially very devastating. Going through, if you don't treat them, you don't find a systemic disease, you are not sure of what you're doing, it starts going fast and there is a melt. So non-inflammatory these conditions you can be treated medically. You should know, because you should not think this is PUK and go for immediate surgery or immunotherapy. Delen sometimes looks like a PUK when there is a large pterygium or when there is an irregular even a chemosis of the conjunctiva. Arcus, poor fitting contact lenses can cause a climatic droplet, can show an irregular cornea, and particularly SLK, superior limbic keratoconjunctivitis, as well as BKC. So all these things have to be ruled out before you jump into a diagnosis of PUK. And of course, you have to do proper investigations. If you feel infective, do a proper scraping, do TCD, CSR, chest X-ray, do a complete evaluation, and if necessary, do a tissue biopsy also. Because these non-inflammatory conditions can just be treated with lubricants and contact lenses. Most of them heal very well. But when it's inflammatory, you see that all these smells. That's why I showed you the pathophysiology. Means that there is a severe inflammation, there is a conjunctival melt, the conjunctival inflammation with a stromal melt. So before going to surgical management, definitely you should start the patient on steroids, at least immunosuppression, something you should start. You cannot directly jump into surgery in all these cases. At least take a week, start them on steroids, evaluate them, and be ready to start immunosuppression. So in these cases, when you see such inflamed limbal conjunctiva and there is necrosis, we have to go ahead with a amniotic membrane transplant along with the conjunctival resection, because that's why the pathology says you will cut off the collagenase, protease, everything, so that the immune cells don't come there and allows the epithelial peripherum to heal. But nowadays, what I do is I just don't do an amniotic membrane. I do a corneal grafting itself. This is known as epikeratophagia, which was popularized by Kinoshita almost 2-3 decades back, but it's not much talked about. What I do is I do not do an AMG. I do a cornea, and then over that I do an AMG, because cornea is still a much better barrier. I make it very thin, maybe 50-60 microns. I put it, make it, shave it, make it very thin, and just put anchoring sutures and fix it with glue. So these actually they do very well. Even if they get an active immunity again, I can see the melt somewhere else, and most of the times this melt area becomes all right, gets fixed very well. So in a epikeratopica, for example, this patient, I have treated him with corticosteroids. That's why the eye is remaining a little bit quiet. So now I cut the conjunctiva and you can see the inflamed or a thickened conjunctiva I am cutting. And then I push it back. And what I was telling is this, all this necrotic debris, all this ischemic necrosis, everything has to be completely cleaned. This is very important. Wash it thoroughly, and because if you're going to put a graft under all this necrosis, that graft also is going to melt. So again here, what I do, I again use a cornea, the anterior lamella. In this patient, actually I had planned for a DMAC, so I'm using the anterior cornea, and then I will go ahead with a DMAC. So because hardly I'm taking 100, 150 microns. So generally I try to use one cornea for many patients because cornea is expensive and also deficient. So you can see here, I keep trimming like this. I make the cornea very thin, really very thin. It's like it starts to crumple. So that amount of thinning I do. And I put it in and put 2 anchoring sutures. And you can see how the cornea is dimpling into the defect because it's so thin. Anchoring suture is a must because sometimes the graft can get dislodged because sometimes inflammation can come. So put 2 sutures. So this we have to hand fashion because I have to put it and then only I can hand fashion it. Cannot prepare it priorly. So after that I trim the cornea and then make fine adjustments so that it nicely goes and sits inside. So if the inflammation doesn't come back, there is actually, you cannot see that there was an area of thinning. The cornea takes up so very well. And fine trimming you have to do. You can see how the graft nicely goes and sits in beautifully. You can see that it nicely sits in. And the other portion, I fix it with glue. So this actually acts as a very good barrier, which I found it was very good actually most of the patients. And then the corneal, that thinning is over, and then you place an amniotic membrane because over the area you cannot leave it as a bare sclera. So I do an AMG here. So in these patients, you can see the left side and how well it heals over a period of time. Even so much of thinning becomes so well, you cannot actually find out there was actually a PUK. You can see in these cases, over a period of time, they heal so well. So this sometimes when the perforation happens, you cannot always do like that how I showed like this. Sometimes when it happens, this is because the sterile melt, if it's a very recent preparation, I clean it and I push it inside. So I put a pilocarpine. When you put a pilocarpine, it goes in most of the times. And then same way we are doing it here. But what I generally do here is I do not extend the hole here. You see that corneal, all the disturbed the cornea, all the necrotic cornea, I'm just cutting, and then even the base I'm trimming. But I do not go full thickness. Whatever area is perforated, I leave. I'm not going to make a big hole here. So all these things I clean. You see how clean. Then the most important step here is you have to make a groove because I'm going to make an exact crescent graft, which is going to see the sclera also. I'm making a groove because you have to suture. There has to be a groove. You cannot just keep the cornea there and suture it to the sclera. It has to go nicely inside the sclera. You make a mark. You can punch crescent, like first you can punch the outer edge. And why I use this method is because I want the exact portion of the cornea where I'm going to transplant. Same from the donor also. So that it matches the alignment, everything matches in. So usually it is slightly bigger. We have to hand fashion it. All these things take time, but it's really gratifying because once these patients are among good immunosuppression or in the initial active disease, they do very well. And all these area of melt, everything comes out very well. See, again, I'm trimming the edges, making it very thin. So again, there is a small trimming here. So in this, I will not be using a glue because it is a perforated cornea, because the glue will not stay there. So here I will suture the cornea. All through I will suture, but I will go lamellar only. I will not go full thickness. So I am forming the anterior chamber. See, the pupil has become round, and in that area and all, I have to go full thickness. Here there is no place of glue here because there's already full thickness perforation. And now it starts to form very well. And here I go partial thickness. I don't go full thickness. because that area perforated is the perforated area, other area it's lamellar. I have not disturbed the endothelium or anything. So here I have to do all the complete suturing because the AC will leak definitely. And over this bare sclera, again we can go with the amniotic membrane graft. So one point what I'm waiting to show you is tuck. I usually tuck in the graft nicely inside the amniotic membrane. Nicely, you should tuck it in. You see here, I will nicely tuck it inside. So this is very important because the you should not leave any gaps so that the AMG stays very well inside, and the healing is very good in these cases. And also I use a 16 BCL, and I usually leave the BCL for around 2 to 3 months, or even sometimes 4 months I leave the BCL because the AMG stays for that amount of time, 2 to 3 months. And you see that it's 16 special lenses we keep. It covers the graft, it covers the entire portion. This is almost 2 months. You can see the graft taken up very well. So this is the pre-op and post-op. And sometimes very bad cases, we do a 360-degree graft. And I think this is quite a 2 minutes video. I think because of short of time, I will not be showing this. So the understanding, the 10 commandments, please, you have to understand the anatomy of the peripheral cornea, rule out infection, look for typical overhanging edges, make sure that it's a peripheral ulcerative keratitis, do all the investigations, see whether it's a Moran's or it's any other associated diseases. Treat medically first. Don't jump into surgery immediately. Conjunctival resection, don't do that. First treat with steroids, oral, topical, and then start. Continue for immunosuppression for 1 to 2 years. Debride the wound completely when you are doing it. Use lamellar graft and AMG. Follow up the patient at frequent intervals. Look for side effects of immunosuppression. Do an LFT or an RFT at least once in 4 months and follow up these patients. Thank you.
Thank you, Dr. Siddharth. It was very nice.